a year. So the summarization of that data is that long-term entecavir and tenofovir therapies are able to reduce fibrosis even in the presence of cirrhosis at baseline. That virologic and biochemical responses, once obtained, are maintained on therapy, that treatment is well tolerated and minimal resistance is detected, that decompensated cirrhotics, especially those with icteric flares, need more urgent therapy, and they actually do pretty well. And finally, that pegylated interferon still is an attractive option in patients with genotypes A and B, and I often will recommend it in patients with genotype A because of their ultimate HBs antigen seroconversion that occurs even 2, 3, 4 years after the therapy is finished. But of course, in patients who have no cirrhosis. Okay, I want to leave this then and go to the next topic, is can NUC therapy be discontinued? And my Swami says no. And are you sure? Yes, it says no. But keep calm. I'm going to sort of help you about whether it's going to work or not. So the first thing is to look at the international guidelines for cessation of therapy in HBe antigen negative non-cirrhotic chronic hepatitis B patients. These are the three organizations, and with the 2016 AASLD level, they have, all of these are undergoing revision, but at least there they said when to stop. They would stop if there's indefinite treatment unless the HBs antigen loss occurs. EASL said that the same thing with HBs antigen loss or seroconversion. And then APASL this year has stated the following. They think it can stop after HBs antigen seroconversion or after HBs antigen loss if it's followed by 12 months consolidation therapy. That means continuous therapy for another 12 months. Or after more than 2 years of therapy with undetectable HBV DNA that's documented on 3 occasions at least 6 months apart. At least 6 months apart means over 12 months. At one point, 6 months later, and 12 months or more later. Okay. Well, why is consolidation therapy pretty important? And here's a study that looked at this. And the top one shows patients who had no consolidation therapy, no treatment for a longer period of time after HBV DNA became negative and the ALT normalized. And then the blue showed group B, which were patients that had variable consolidation. And then the lower two showed consolidation for either 7 months or 28 months. Now, there wasn't much difference between 28 months or 17 months, but there was a difference between 7 months and either 17 months or 28 months. So that seems to be an important issue. So one could consider stopping therapy if HBV DNA and ALT have been normal for at least 2 years, followed by 12 to 18 months or more of consolidation therapy. And then after you stop the therapy, what's really important that you monitor these patients with ALT monthly times 3, then every 3 months times 3 for the first year, then every 6 months. And that the HBV DNA then is monitored every 3 months for at least 1 to 2 years. And I would usually monitor them for about 2 years. For clinical relapses that occur with a rising ALT or an ALT that's more than 5 times the upper limit of normal, then you need to do weekly or biweekly ALT levels, bilirubin, and INR. And what I've found that what happens with people who are not used to treating patients with hepatitis B when you stop their therapy is that once they stop it, the ALT goes up to 200, they get nervous, or the HBV DNA increases to a million or something like this, they tend to stop therapy and start them on treatment. And if they just wait a little bit longer, if everything else is solid, they just wait a little bit longer, their disease will regress, and then they haven't had to be treated after all. The triggers for NUC retreatment are impending or overt decompensation, persistently high ALT elevation with repeated clinical relapses, or a high risk for disease progression exists, or if there is a risk for HBV reactivation because the patient has been placed on immunosuppressive agents or on chemotherapy. Now this is just sort of a synopsis of studies regarding this. We know that most relapses happen within 1 year off of therapy and rarely after 2 years. That approximately 75% of clinical relapses occur beyond 6 months with entecavir treated patients. That a marked ALT flare, that is more than 2,000, is rare, as is hepatic decompensation. In fact, in all these studies that they've looked at, I think there's been 1 death. There have been some liver failures, and even a liver transplant, but there's been only 1 death. And from 50 to 75% of the patients may not require retreatment. This is really the critical thing, is that if you do this, you may get by with stopping therapy in these patients, and they will not need to be taking therapy all their life. And finally, proper off-therapy monitoring is mandatory to prevent untoward events. In all cases, however, a consultation with a hepatologist is well advised so that patients are not, their therapy is not started when it really doesn't need to be. All right, the last part is just a few slides on reactivation of HBV. This is a really critical thing here because we need to do a better job of preventing reactivation from occurring. And that's because the outcome following HBV reactivation can result in some terrible things. Now, however, in this case, about 75% of the patients that reactivated were asymptomatic. But you see that about a quarter of them developed severe hepatitis, of which some of those, half of them, went on to develop fulminant hepatitis and death. This is why it's really important to be aware of this. Here's some guiding principles. The first is that if you have a patient who's had a resolved acute infection with immunity, I can talk to you about occult hepatitis B, and I can tell you about patients who have had HBV DNA detected in their liver after resolving their infection for 23 years or more. But the fact is that, from my opinion, most of patients with a resolved acute infection with immunity, reactivation is rare and no action needs to be done. On the other hand, if you have a patient who is HBs antigen and HBV DNA negative, but has a total anti-HBC as positive, particularly without antibody, less than 3% to 25% will reactivate, and these patients at least need to be monitored. And then there's a group of patients who are HBs antigen or HBV DNA positive, and 25 to 80% will reactivate, and they need to have preemptive therapy. Here's just a slide looking at preemptive therapy, the outcome following reactivation with immune-mediated inflammatory diseases. And you can, I'm sorry, let me move forward. We saw that before. The last one, I want to just draw your attention to a study that was done and published by Professor Reddy in January of last year. Excellent study in which they looked at the AGA guidelines on the prevention and treatment of HBV reactivation during immunosuppressive drug therapy. I don't have time to go through all of these with you, but I do want to bring your attention to looking at this study because it deals with immunosuppressive agents that have a high probability of leading to reactivation, like the B-cell depletion drugs, like rituximab, and then drugs would have a moderate amount of opportunities to lead to reactivation. And what you should do, should you prophylact, should you monitor, should you do no therapy? And so I call your attention to doing this and to looking at this because it is an excellent study. So preemptive therapy. Begin therapy at least a month before biotherapy. That's important. And then discontinue 6 to 12 months after the end of therapy. Longer periods of time to discontinue if they're on rituximab. And protection from a serious outcome is approximately 100% with preemptive therapy. And this sort of shows you a study that was done. This is one of the older studies with lamivudine, looking at 7 to 13 studies put together. And what you see here, that they had about an 80% reduction in risk for reactivation or hepatitis, and very little failure, liver failure or death in these patients. I will tell you with entecavir or tenofovir, it's almost 100% reduction in risk if you use preemptive therapy. What about monitoring these patients? There's a couple things you can do. You can either both of them monitoring for 4 to 8 weeks. And you can either monitor with a highly sensitive HBs antigen assay. Most of the chemiluminescent assays would do here. and then begin antiviral therapy when the test becomes positive, or you can monitor with a highly sensitive quantitative HBV DNA test with a very lower limit of detection, and begin antiviral therapy when the result is more than 20 IU per ml. So those are the couple of ways that you can do it. And my final slide is here. These are some factors that are associated with a poor outcome if the patient develops fulminant hepatitis. If they're of Asian ethnicity, and probably a genotype or genetic results for that. If there's a delay from treatment initiation to when HBV reactivation occurs, if there's high levels of HBV DNA and ALT that occur, and of course I find it the use of lamivudine rather than entecavir, tenofovir, recall. So this really ends my talk. I hope that I've given you sort of an overview, if you will. We've talked about guidance documents. We've talked about can you stop therapy, and the answer is yes. And you just have to monitor them carefully, but you can stop it, and then they will be on drug. And then a little bit about reactivation, because it is important, because people die from reactivation. So I thank you for the opportunity of starting this program off. Again, I'm really appreciative of always coming to Myanmar, and for the friends that I've developed here. Thank you so much.
Thank you. Stay there. Questions? I have a question. You imagine, you see a patient in this country now. He has chronic hepatitis B. What are the persisting indications for PEG interferon? You can summarize the indication for treating this patient by PEG interferon without antivirus drugs.
Well,
Young, what is your...
Well, you know, Danielle, that patients with C and D don't do very well with PEG interferon. A does better than B, which does better than C, which does better than D. So the Bs actually might do well. So if I had a patient with genotype B, I would maybe consider treating them for a year, or maybe 2 years, with PEG interferon. Mainly because I know that if I stop it at that point, they probably will not need to be retreated after that. But I would look at them obviously at 6 months to see how they're responding. Quantitative HBS antigen would be very useful to make that decision, and then make a decision whether I want to go on at that point. 6 months, I think, would be very useful.
HBS antigen quantification is useful for indication too. If the level is low, you know that the response would be higher in patients with low HBV antigen before treatment?
Yes, you know, if you look at Janssen and some of their other studies that they have done that have said that if you can even look at them at 12 weeks. And I asked him one point about that, because he said if there's any change in the HBS antigen between baseline and 12 weeks, and he actually meant any change, but I think it's better if they have at least a half a log to a log drop in HBS antigen within that first 12 weeks, rather than just any change.
And you stop treatment?
Yeah, and I think they would be doing well at that point. You might want to then consider continuing the treatment with them, yes.
Okay.
Yeah.
Questions? Another point. I would like to know if it is realistic to envisage cure of hepatitis B. And we could have absolute cure with elimination of cccDNA, or functional cure in abolishing HBsAg. What is your feeling?
Well, the buzzword now is functional cure. I'm not sure what
it's a close future.
Yeah, what that means about functional cure. But you know, there are a lot of very interesting. This is a whole new talk, obviously. But the nucleotide, I think the things that cause destruction or poor assembly of the nucleocapsid, I think those products look very good.
Yeah.
The products that maybe deal with cccDNA are coming along. The products that alter the assembly or resolution of the HBS antigen, so they're packaged and they're not expressed from the cell, they stay within the cell. I think those are looking good. The siRNAs, the small interfering RNAs, the problem is that they have to get into every cell, and that's why probably they don't work as good as you'd like them to work, because not every cell is affected by it. But there are a lot of things, and that's a whole new talk, but there are a lot of places. I think it's going to take more than just one agent. I think like HIV, you're going to have to deal with a variety of receptors. The receptor ones are also excellent. And so receptors, attacking the nucleocapsids, the HBs antigen assembly, small interfering RNAs. I think putting all those together may be the reason that you could get not just to a functional cure, but maybe basically to a cure also.
What's your feeling? 1 year, 2 years?
Well,
Your feeling?
There are some that are already in phase 2, phase 3 trials, I should say, already. The small interfering RNA arrowhead product, I think. But the others are sort of coming along, and yes, it's going to take a few years to do that. At a very high price, I might say. Again.
You're welcome again.
Yeah. Thank you very much.
Thank you very much. No questions? Parfait? No? Grave? No. Happy?
Thank you, Lane, for your excellent talk. And second speaker is Dr. Anuchit. He is a Major General Secretary General of the Liver Foundation of the Thailand section of the Digestive and Liver Disease Department of Medicine, Pramongkakut Hospital, Bangkok, Thailand. Actually, he is not a stranger to us. He's been here all along. This may be his fourth time, and he's been a long friend of us with Prof. Kemawan and me since 19